Hello, my name's Joel Dunning and we're here at the STS 2024 and I'm delighted to be here with the unbelievably hardworking Patrick Myers. Patrick, as well as being Chief of Surgery in Lausanne, you're Secretary General of EACTS and you're the President of the CTSNet, and you've been up since 6 a.m. doing meetings, so I'm very grateful that you've spent a bit of time to come and talk to us. And you're actually in a session all about trials and studies that everyone needs to know about, and you're in particular talking about atrial fibrillation, and in particular lone and hybrid AF. So maybe you could start by telling us all about your session and what you'll be telling the STS conference about.
So this is a session that we've organized with EACTS and STS together, and we're trying to highlight the trials that surgeons need to know about in their daily practice, in their discussions with cardiologists. And of course, we're going to be having the SAVR versus TAVR trials, going into the details with investigators from the trials themselves. And that should be some pretty lively discussions. And one subject that is actually an incredibly prevalent disease, but that is undertreated, is atrial fibrillation. During the whole meeting, there'll be new guidelines that are going to be presented. Also, some reminders on how, during mitral valve surgery, we need to be treating atrial fibrillation. That's a very high class of recommendation for that, and it's really undertreated currently in the United States.
Yeah, and it's a real burden of disease, isn't it? This is a real problem to patients, isn't it?
Absolutely, absolutely. And it's a burden of disease, and that has a high morbidity and mortality. And so it's something that we can address. So in this session, what I'll be talking about more specifically is the hybrid management of atrial fibrillation. Our colleagues from cardiology and from EP do a fantastic job of managing with medications, with catheter ablation. But that's mostly for paroxysmal AF, which represents just 25% of the atrial fibrillation. For the persistent or long persistent atrial fibrillation, their results are actually pretty poor. In a large meta-analysis, it was fewer than 50% of patients who were free of atrial fibrillation after a year. So there's definitely something to be done there. And we had at our EACTS meeting in Vienna last year, 2 late-breaking trials just on this subset of patients, looking at a hybrid management of atrial fibrillation.
So from your point of view, what do you think the ideal hybrid operation is that surgeons should offer? Because certainly I've found cardiologists quite receptive to this, because there are real bits that they can't do, and then there's bits that they're very good at. What is the ideal way you can perform hybrid AF?
Well, I think it's really understanding that this persistent, long persistent AF is not cured by catheter ablation. And our colleagues from EP can take these patients back. But actually, what will have a much bigger impact is if we have a hybrid approach, where we start with a thoracoscopic ablation. And there are these 2 main trials, HeartCap and CEASE-AF, which showed doing different lesion sets, pulmonary vein isolation, box lesions, left atrial appendage occlusion. And they showed that with that, rather than having a 30 to 40% freedom from atrial fibrillation at 1 year in the catheter ablation group, if you add that hybrid step to it, they're actually between 70 and 95% free of atrial fibrillation, depending on the definitions. If they're completely off medications, if they're off class 1, class 3 antiarrhythmics. So the results, effect size, that's absolutely humongous. You're practically doubling the freedom from atrial fibrillation. So that has a huge impact on patients.
And you don't actually have to have the cardiologist in your lab, or you don't have to go to their lab. These can be spaced out, can't they?
Absolutely, absolutely. In one of the trials, they decided to do it on the same day. So they would do, the surgeons would do it independently, thoracoscopically, and then within the same anesthesia would transfer the patient to the cath lab and then check if they had done transmural lesions and if they were effective. And if they weren't, they could do the touch-ups in the same sitting practically. In the other, they did it as a second procedure when necessary.
And who do you think is the ideal patient for one of these procedures? Do you think they should be quite symptomatic, or do you think they should be younger, or who is the perfect patient to have hybrid AF surgery?
So we don't know, ultimately. These trials, since you have such a big effect size, it's very easy to power these trials. And for example, in HeartCap, they just had 40 patients, 19 and 22 patients in the 2 groups. So that's the beauty of having an intervention that has such a high effect size, is that you don't need many patients to prove that it has a statistically and clinically significant effect. Now, we don't, with these small groups of patients, we don't have subgroup analyses and things like that, and this is something that we need to learn more about. But I think surgeons need to understand that this is a huge burden of disease, a large patient group, and that through very simple procedures, we can improve the outcomes for patients. What the trials also showed is how safe these procedures are. Very few patients had pacemakers, very few patients had any bleeding or any rehospitalization or things like that. That the actual complication rate was not significantly different from just doing a catheter ablation.
So, I mean, the outcomes of these studies, as you say, tiny numbers of patients, huge differences. I mean, this is barn door shouting at us as a group of surgeons, isn't it? You know, what do you think the barriers are? Do you think it's barriers of interaction between cardiologists and surgeons, or just not thinking about this group, or them getting lost, or what are the barriers?
In all honesty, I don't know. My impression is that it's multifactorial. One is that our colleagues from EP are very good at what they do, and they can treat and cure a fair amount of these patients, even if it does recur. And a recurrence just means going back to the cath lab and doing another procedure, which is not very invasive. So I think in many cardiologists' mind, redoing a procedure through a catheter procedure is much less burdensome than doing a thoracoscopic procedure. On the other hand, from my standpoint, if you do the whole procedure in one go and you have an 80 to 95% cure rate at 1 year, that's pretty good.
Yeah, I mean, I've certainly seen several of these procedures, and 4 hours under general anaesthetic, sort of buzzing and burning. You know, it's quite debatable as whether that is less morbid than 3 5mm ports. I've saw Mark Lemaire doing incredible 3 5mm port work. You know, takes an hour. You know, I think it probably is equivalent, exactly as you say, not coming back for multiple procedures. I think it definitely is something that, you know, collaborating, you know, really can work well with. So I guess maybe that's going to talk to your EP docs might be one of those key things, really. So so you mentioned these guidelines are coming up. Do you feel that these guidelines are going to be talking to the surgeons about, you know, recommendations for these procedures?
Absolutely. I mean, I don't know what the guidelines, since I was not on the writing committee, so I can't tell you what is contained in these guidelines. But I think definitely there's a realization that atrial fibrillation, be it at the time of mitral valve surgery or other cardiac surgery, and as a lone disease that can be treated surgically with very good results and high safety, that as surgeons we're undertreating this disease, and we need to do a better job of it.
And I guess the final point is that clipping off the left atrial appendage, the Laos trial and several others have shown you that really does, for like no morbidity, you know, does protect patients, doesn't it?
Absolutely. It's a very low-cost intervention in terms of safety, but has a huge impact in terms of outcomes.
Well, it's been great chatting to you. It sounds like the party's starting already in San Antonio here. But thank you very much for your insights, and thank you for all your leadership over the years with CTSNet, and thanks for coming to talk to us.
Well, thank you, Joel. A pleasure to talk to you, as always.